So cardiomyopathy is a disease of the heart muscle that can be inherited or acquired. So it can be both. It can be congenital or it can be acquired and can affect people of all ages. And it is affects the structure, function, and electrical system of the heart. All the three are affected. Dilated cardiomyopathy is a disease of myocardium characterized by impaired systolic function and dilatation of both left and right ventricles. The major cause of heart failure and arrhythmias in young adults. The pathogenesis is progressive enlargement of one or both ventricles to the stage that interaction between actin-myosin filaments become inefficient, leading to reduction in stroke volume and systolic impairment results. The severely dilated ventricles have a low wall thickness to diameter ratio, leading to remarkable increase in the ventricular wall stress and oxygen demand, and further decrease or impairment in systolic function. So the Laplace's law applies here because it becomes so dilated. So the low wall thickness to diameter of the ventricle, so wall thickness divided by diameter of the left ventricle is called the low wall thickness diameter ratio. What is the etiology? Majority of the cases are idiopathic, but they can be familial, post-viral infection, and can present as part of disease process such as ischemic heart disease, hypertension, diabetes, malformation syndrome, alcohol excess, neuromuscular disorder, inborn errors of metabolism, and exposure to cardiotoxic drugs, especially chemotherapy and illicit drug use. So history taking is very important to find out whether it is idiopathic or secondary to IHD or hypertension or diabetes or alcohol excess or inborn errors of metabolism. All these things have to be included in your answer. The clinical features in the early stages of DCM, patients may be totally asymptomatic. That is a very deceiving picture that you will get. As the condition progresses, patient may develop either heart failure or arrhythmias. There may be embolic events and sudden death also is possible. So these are the 4 presentations that you may have. How do you diagnose this? Echocardiography plays a key role in the diagnosis of the dilated cardiomyopathy and additionally used to identify high-risk patients and predict prognosis in these patients. So using echo, how do you diagnose or assess the prognosis? What are all the points that you have to see in that? Any idea, Muthmani?
Sir. Sir.
The fractional shortening of less than 25% and or ejection fraction less than 45% is the first finding that you will get. Then left ventricular end diastolic diameter should be greater than 117% of the predicted value of 112% corrected for body surface area, and increased sphericity, that is ratio of length to diameter of the ventricle, and severe impairment of left ventricle may be associated with presence of spontaneous echo contrast, which should then prompt a careful assessment for thrombus. So because the contractility is poor, intracavity thrombus formation is one of the major complications. That is why you get the thrombus get dislodged and embolic events happen. And diastolic dysfunction, or what is called restrictive or pseudo-normal, is also indicator of poor prognosis. The most important thing is tricuspid annular proximal systolic excursion. That is because the myocardium gets so dilated, the annulus of both tricuspid and bicuspid, mitral and tricuspid valves, the annulus gets stretched out. So they start moving during the systolic excursions, which is more than 15 millimeters, illustrates the right ventricular dysfunction and predicts a poor prognosis. So if diastolic dysfunction and tricuspid annular proximal systolic excursions, all these things will definitely give a indication for poor prognosis. So unless you do an echo, even if it is an urgent Lscs, we have to find out whether these things are present, and if this indicator of poor prognosis is there, automatically what should you plan? because even if it is a emergency Lscs, you should buy time to do this important investigation, echocardiography. And supposing the echocardiography shows a diastolic dysfunction as well as this particular point of tricuspid annular proximal systolic excursion, what should you, how will you alert yourself, or how will you equip yourself? You must go for more invasive monitoring. You should have an arterial line, central line, and you must not extubate the patient on the table. You must plan for elective postoperative ventilation. Okay, so you, just like what you have mentioned, you cannot just extubate these patients on the table, and you must have all cardiac support drugs, everything loaded and kept ready so that you can manage this patient. And in this sort of situation, GA will be a better choice compared to regional technique. So mitral regurgitation is frequently seen in patients with dilated cardiomyopathy, and this can be the cause or the consequence of PCM. And what investigations you have to do? You have to do complete blood count, electrolyte, mainly sodium, potassium, and brain natriuretic peptide or NT-pro and BNP for assessing the degree of failure. If it is any, CXR will show a cardiomegaly. EKG may show sometimes left bundle branch block, and echo will give you all the findings which I mentioned in the above. Management, the main aim of medical management is to control the symptoms and prevent further progression of the result, resulting in complications. So the commonly used medical management is AC inhibitors, which inhibit renin-angiotensin-aldosterone system, improve dyspnea and exercise tolerance, reduce hospital stay, slow disease progression, and reduce mortality. So these are all the advantages of putting the patient on AC inhibitor. Similarly, ARB, useful if patients cannot tolerate AC. Some patients develop cough or allergic reaction to ACE, so better to put them on ARB. Little benefit if used with A. So there is no point in combining both. So you can put them either on ACE or ARB. Beta blockers to reduce mortality in heart failure. If already established heart failure is there, they may be given beta blockers. Aldosterone inhibitors like spironolactone or eplerenone reduce the mortality in heart failure. This does not cause the gynecomastia, which is a side effect of spironolactone. And atrial natriuretic peptides are also given as a diuretic, natriuresis, and vasodilatation, but they can be given only as an IV, so they are not available orally. And anticoagulants are also given sometimes, indicated in the presence of systolic dysfunction and if there is an intracavity thrombus. So all these drugs are commonly given, but when the patient is pregnant and non-medical management, the patient could have already had a partial left ventriculectomy and ICD placement and other supportive devices may be there. And preoperative management, medical therapy, regular medication should be continued in all patients and optimized patients with symptoms of heart failure. Arrhythmia should be appropriately treated before operating via drug therapy. Echocardiography is vital to assess the extent of ventricular dysfunction and presence of any valvular abnormality. So coming to the anesthetic management, goals of anesthesia are avoid myocardial depression, which you mentioned, maintain adequate preload and prevent increases in afterload, avoid tachycardia, prevent sudden hypotension by careful titration of anesthetic agents. Now coming to the choice of local and regional anesthesia technique, peripheral nerve blocks offer minimal hemodynamic changes. Central neuroaxial blockade reduces afterload and improves cardiac output, but the accompanying hypotension may be causing myocardial hypoperfusion and which must be prevented. So central neuroaxial blockade is not an absolute contraindication. If you can judiciously use this, definitely it is more welcome because it will improve the cardiac output. Now coming to general anesthesia, avoid overdose of induction agents since the circulation time is impaired. So because of the cardiac failure, the circulation time may be prolonged. So don't rush to give more and more induction agent, wait for the arm brain circulation time may be prolonged, so wait for that adequately and then slowly give a titrated dose. Etomidate causes least hemodynamic changes. Ketamine should be avoided as it increases SVR. Propofol has got a negative inotropic effect but useful in reducing the SVR. So if you give it in a judicious manner, you can definitely use them. A combination of these two, that is ketamine and propofol. Ketofol may be a good choice because it will improve the analgesia as well as the ill effects of propofol also can be counteracted. Volatile anesthetic agents and myocardial depression in high concentration will happen, so you have to use them judiciously. Opioids have minimal cardiovascular effects and reduce the requirement of anesthetic agents. Coming to monitoring, arterial and central venous cannula should be used, especially if you find the echocardiographic findings which are indicative of poor prognosis. And transesophageal echocardiography provides a dynamic assessment of myocardial function. Esophageal Doppler may be the alternative to transesophageal echocardiography. Coming to cardiovascular support, inotropic support can be provided by a variety of agents like phosphodiesterase inhibitors, milrinone or amlenone, and levosimendan, dobutamine, and dopamine. So the regular use of these drugs may be required. And noradrenaline can be used to treat hypotension, but care should be given to increase the SVR increase and afterload. Biventricular pacing and intra-aortic balloon pump may be required in very extreme of severe dilated cardiomyopathy cases. Postoperative care should be transferred to intensive care unit until to allow all invasive monitoring and optimization of postoperative hemodynamics and fluid therapy. Adequate analgesia reduces the deleterious effect of increased SVR. And what are all the predictors of poor outcome? LVF, ejection fraction less than 20%, elevated left ventricular end diastolic pressure, left ventricular hypokinesia, and non-sustained ventricular tachycardia. If these are all present before the surgery or happening during the surgery, they are considered as poor prognostic signs. And coming to the considerations in pregnancy with the DCM, the use of AC and ARB contraindicated in pregnancy. Diuretic usage should be judicious since preload preservation is important. Central neuraxial blockade like epidural, combined spinal epidural, or bilateral TAP blocks are safe for elective cesarean section. If maternal fetal distress is the indication for surgery, Lscs GA may be the best option. Invasive monitoring and vigilant post-op care are essential for successful outcome. So these are all the points I think you have to modify in your answer. Okay.
Thank you very much, sir.
Welcome.
Any questions or doubts from the students?
The biggest advantage is nobody is asking any question.
So we can ask some questions, sir.
We have already asked him how to.
Okay. So can I add one more point, sir? Please, if you have permission. Our cardiologic friends, they are very informative in their echo report. Sometimes they use abbreviations, which we know the significance, but we fail to recognize it. Usually they write it as TAPSE, TAPSE. Have you noticed in the echo reports, TAPSE? That's what sir told. Tricuspid annular plane systolic excursion. When the RV is vigorously contracting, the tricuspid valve annular plane moves upward. Normally, it moves more than 19 millimeter. Between 14 millimeter and 19 is intermediate, that is borderline. If it is less than 14, the RV is not contracting, it is failing. So RV dysfunction is a very, very significant, because LV also we can support with other inotropes and vasoactive drugs, but RV function is a different, totally different dynamics. So in a pregnant patient with DCM, equally RV is also failing. So during general anesthesia, we need to be very judicious in using positive pressure ventilation. and we have to use we should use all the available techniques to reduce the PCO2, or we should not allow the PVR to rise. The PVR should be closely monitored and managed. Pulmonary vascular resistance plays a significant role in preventing right ventricular failure. Similarly, as Sir has already detailed about maintaining good hemodynamics with adequate systemic vascular supply pressure maintenance, because sudden hypotension indirectly affects or directly affects the coronary perfusion pressure also. So as Sir has already told, law of Laplace, the wall stress increases the stress on the myocardium. So already they are in for ischemic problems also because of the too much of dilatation. Coronary ischemia is also a problem. Myocardial ischemia is also a problem. So when you suddenly drop the pressure, hypotension, it causes coronary supply decline also. So myocardium will be forced to fail. Okay, so we must take care of RV as well as SV. Thank you, sir.
Thank you.
Thank you,
Can
sir.
we move to the next topic, sir?
Yeah. All right.
Next topic, Dr. Venkat.